this is important. Make sure, and that's why it's in bold, hold on to your patient throughout treatment maneuvers. You may see a couple patients with this if you're just delving into this area and not have anybody that demonstrates a real strong falling response, but then you run into one. You always have to be ready for it. Two common reasons why patients get strong falling responses when you do treatments is if you do a treatment that was actually ineffective for posterior canal canalithysis, when you sit the patient back up, the nystagmus reverses because the debris is settling back down in their posterior canal, and that can create instability. And also, just from experience, another common reason why you can get really strong falling responses is whether you use an Epley's, a modified Epley's, or Semence maneuver, there's a small chance in the side-lying position, position 3 of your modified Epley, of the debris just transiently wandering into the anterior canal a little bit. And so it goes from the posterior canal into the anterior canal, and when you sit them up, it plunges from the anterior canal back into the utricle. And I found that when that happens, patients can get really strong falling responses. But it also indicates that likely the debris went back into the utricle like you wanted it to, right? And if that does happen, the debris is plunging out of the anterior canal back into the utricle. You would get an excitatory eye movement from the anterior canal, which if you're treating the right side should be downbeat right torsion. Versus a reversal from the right side, the debris just settling back down in the posterior canal would be downbeat left torsion. So you can really, if you watch the eye movements close, have a good idea if the debris just settled back down in the posterior canal or was transiently in the anterior canal as a complication of the treatment. But main teaching point is hold on to your patients because you don't want to have them have a fall while they're with you, obviously.